Good morning, everyone. Today's my topic for seminar is Pankey, mann, and schuyler philosophy for full mouth rehabilitation. So these are the content under which I am discussing the topic. So coming to the introduction, planning and executing the restorative rehabilitation of decimated occlusion is probably one of the most intellectually and technically demanding task factor for the prosthodontist. The stakes are high and the failures are costly in the full mouth rehabilitation treatment. So one must learn the treatment before starting the procedure. The statement by McKillum, he told that the time should be over where we are the dentist of the teeth or maybe a few teeth. Let us be the doctor of mouth. Full mouth rehabilitation, by definition, is the restoration of the form and function of masticatory apparatus to as nearly a normal condition as possible, whereas occlusal rehabilitation is defined as a restoration of functional integrity of dental arches by use of inlay, crowns, FPD, or a partial denture. So, the most common complaint of the patient when he visits to a dental clinic for the rehabilitation was an aesthetic impairment. It can be a difficulty in mastication or pain and sensitivity because of the occlusal tear. So these are the basic patient history when the patient come to a clinic with the chief complaint of teeth-related problem like adhesion, difficulty in chewing, pain, and sensitivity. From this, we can conclude, or from this and from the clinical examination, we can conclude that the patient has lost his vertical dimension. A patient has symptoms in the temporomandibular joint because of the decreased vertical dimension, or the patient, because of the severe adhesion, has developed pain, so indicated for root canal, and patient can be convinced here for full mouth rehabilitation treatment. Also, this thing happens just because there are many factors which can conclude this adhesion erosion problem. It can be because of GERD, that is gastroesophageal reflux, because in some cases the patient is suffering from this disease because of the continuous exposure of the acid to the teeth. It might lead to the erosion of the tooth, continuous vomiting sensation, or the swimmers because of the high fluoride content in the water, vitamin C, high citrus diet, high carbonated drink if patient is taking, it leads to the tooth wear and ultimately leads to the adhesion of the teeth and decrease in the vertical facial height. So the broken mouth dentition can be classified into two: the diseased mouth or the worn mouth, or the congenital abnormality like acquired or because of the disease. So coming to the need of occlusal rehabilitation now, once the patient is entered in your clinic and you have noticed there is loss in the vertical dimension, the full teeth are treated. So you need to tell patient about the condition and why there is need of rehabilitation. You need to explain. So now vascular tissue of the periodontium can be stimulated only by the function of the tooth. You need to tell, like once the teeth are again rehabilitated, the vascular periodontium can be simulated and it will be good for the patient's oral condition. Now the mutilated teeth, they have lack of stimulation, so there will be less stimulation and there will be more malfunction. Though full mouth reconstruction improve the general tone of the facial structure, it also improve the function and the teeth will feel stronger. You need to explain all this thing to the patient. Sorry. So the aim and the objective is to re-establish a state of functional as well as biological efficacy where teeth and their periodontal structure, the muscle, the muscle of mastication and the temporomandibular joint mechanism all functions together in synchronous harmony. Whereas the objective is to to relieve the stress in the stem of the temporomandibular joint on the teeth and to minimize the stresses which are not required. So coming to the introduction, coming to the indication and the contraindication. First, the indication: to restore the impaired occlusal function because of the severe adhesion, or we can say because of the bruxism patient, we need to rehabilitate the occlusal plane first, and also to preserve the longevity of the remaining natural tooth. To preserve the remaining natural tooth, we have to go ahead with this treatment. Also, to maintain the healthy periodontium, improve aesthetic, and to eliminate the pain and discomfort of the teeth and supporting structure. Coming to the contraindication, Contraindication, we generally contraindicate in the malfunction mouth, where the FMR should not be taken place as a preventive measure unless it is definitive evidence of the tissue breakdown. We should not carry out this treatment in patient who doesn't require it. And in short, if we can say that if there is no pathology, we should not go for this treatment. So there are different classification which is given. So one by one, we'll see the classification, which is for the first classification is the Turner and Whistler classification in 1984. Now he divided the full mouth cases, the decreased vertical dimension cases, in three categories. Whereas the first category says there is an excessive wear of the tooth structure, but there is no loss with the loss of vertical dimension. The second category says there is excessive wear without the loss of vertical dimension of occlusion, but there is still freeway space available to rehabilitate or to increase the bite of the patient. Whereas category 3 says that excessive wear of the tooth without loss of vertical dimension, but with the limited space available. So coming to the Charles and Vickers classification, the group 1, in which we have three subclasses. So class 1, patient with the coalesced vertical dimension of occlusion because of shifting of existing teeth caused by failure to replace missing teeth. Class 2, patient with collapsed vertical dimension of occlusion because of loss of posterior teeth in one or both the jaw with remaining teeth in unsatisfactory occlusal relationship. Class 3 is the patient with collapsed vertical dimension of occlusion because of excessive attritional wear of the occlusal surface. Coming to the group 2, in group 2, there are two subclasses. The class 1, patient with all sufficient natural teeth present with satisfactory occlusal relationship. In class 2, patient with limited teeth present but in satisfactory occlusal relationship require aid in the form of occlusal rims. Class 3, or we can say group 3, patient requiring maxillofacial surgery or the orthodontic corrective treatment procedure as an aid in restoring the vertical dimension. And group 4 is the patient in whom sectional treatment is required over an extended period of time because of the status of the health of the patient, age, and the economic factors. So coming to the etiology, diagnosis, and the treatment planning, the etiology of this disease can be diagnosed, can be get to know by case history recording, by seeing the clinical scenario, clinical condition in the patient's mouth, and the diagnosis can be drawn with the help of photographs and the radiograph of the patient. Now, once it is the etiology is diagnosed and the proper diagnosis is made, treatment planning can be carried out. Now, in the treatment planning, before starting, an examination should be carried out. A thorough medical history, dental history, behavioral examination, radiograph, and the photograph should be mentioned in the case chart before starting with the treatment. A patient consent is obtained before starting the full mouth rehabilitation treatment. Now, once we have diagnosed the cases of full mouth rehabilitation, a diagnostic mock-up is necessary to provide a temporary crown for the patient. So before diagnostic mock-up, occlusal discrepancy in the centric and the eccentric occlusion should be eliminated. A proper centric occlusion can be obtained. Before that, discrepancy should be eliminated. Diagnostic preparation should be carried on the stone cast to relieve any existing, to reveal any resistance and retention problem. If there is any problem, that particular tooth can be always go ahead with the crown lengthening procedure, depend upon the amount of the bone supporting bone presence. Thus, the planning of the gingival margin or surgical crown lengthening can be done. Then the wax is used to shape the crown and the prosthesis can be planned, and the diagnostic mock-up can be used for the temporization. Now, these treatment plan can be divided into three phases, that is pre-prosthetic, prosthetic, and the maintenance. As I say, pre-prosthetic, we can go ahead with this pre-surgical crown lengthening procedures. And in the prosthetic phase, we'll plan an immediate and the definitive. And immediate, we can give a verticalization splint to the patient for time being. Once the patient is habituated at the particular raised vertical dimension, we can give a patient a definitive prosthesis at the same vertical dimension. And the maintenance phase, it is very essential in the full mouth rehabilitation cases for the good prognosis of the prosthesis. So there are many philosophy given for rehabilitation So the first and the most accepted, widely accepted philosophy is the Pankey mann and Schuyler philosophy. Now Schuyler has given many principles, and Pankey has designed an modified instrument. Now these three scientists, the three doctors, have come together and they have mentioned a philosophy regarding to treat the full mouth cases. The philosophy, so the entire philosophy is known as Pankey mann and Schuyler philosophy. Now, the principle of occlusion advocated by Schuyler was there should be static coordinated occlusal contact of both of the maximum number of teeth when the mandible is in the centric relation position. Now, whenever the mandible is guided, when the mandible is closing in the centric relation position, there should be, in the static coordinated form, there should be a proper maximum intercuspation of both sides of the jaw. The next with the anterior guidance that is in harmony with the function in lateral eccentric position on the working side. So there should be a balancing in the working side contact in the extrusive motion. There should be disclusion of the posterior teeth when the anterior teeth are coming in contact. And the disclusion of non-working incline in the lateral exclusion and the group function of the working side incline on the lateral exclusion. So this philosophy was predominantly based on the spherical theory of the occlusion and on the importance of the cuspid teeth as discussed by D. Amigos. Now, D. Amigos has given a theory on the canine guided occlusion. As the modification of canine disclusion, the PMS philosophy to have simultaneous contact of the canine and the posterior teeth in the working exclusion, that is in group function, and only anterior teeth contact in the protrusive exclusion movement. So the sequence advocated for this philosophy, the part one being the examination, diagnosis, treatment planning, and the prognosis of the patient. The part two is the harmonization of the interior guidance for the best aesthetic, functional, and the comfort reason. Part three is the selection of acceptable occlusal plane and the restoration of lower posterior occlusion in harmony with the anterior guidance in a manner that will not interfere with the condylar guidance. And the fourth one is the restoration of the the upper posterior teeth in harmony with the anterior guidance and the condylar guidance. The functionally generated path given by Mayer is closely allied in this part of this reconstruction. So coming to the step in harmonizing the anterior guidance. Now the step one being established a coordinated centric relation stop on all the anterior teeth. Once the centric relation stop is established, an extended centric stop forward at the same vertical to include light closure from the postural rest position. So this stop extends So in this condition, in the steps 2, the extend centric stop forward at the same vertical to include a light closure from the postural rest position, that is in the long centric. Third step is establish a group function occlusion in the straight protrusion, and the fourth step is establish ideal anterior stress distribution in the lateral exclusion. So coming to the registration of the lower anterior teeth, the lower incisal edges are starting point of the anterior guidance and the view when speaking. So the four decision, that is the incisal edge outline, the curvature of the incisal plane, the height of the incisal plane, and the horizontal position of the incisal plane should be adjusted first. So the restoration, coming to the restoration of the upper anterior teeth. Now, once the lower teeth is positioned accordingly, the restoration of the upper teeth can be done. Now, in the order to successfully restore this upper anterior tooth, the correctness of the position of the teeth can be verified in the mouth with the precise incisal position, the labial contour, and the lingual contour of the teeth. Now, there are 7 factors that work together to dictate the above determinants. So, the first one is the maxillomandibular relationship. Once the position of the mandibular teeth is done, the maxillary teeth is positioned according to the mandibular teeth, the midline, the alveolar ridge relation, the nasopalatine fossa relation. The second thing is the lip support. The lips prominence should be matched. The lip should be adequately supported by the teeth. The fullness should be obtained. The lip closure path can be checked. The tooth to lip relation during the formation of F and B sound should be checked. The envelope of the motion can be checked before finalizing the temporization. And the tooth to tooth relationship during S sound and the neutral zone should be recorded. The selection of acceptable occlusal plane. Analysis of the natural teeth through selective grinding can be done. Analysis with the Facebook mounted cast with the proper set of condylar guidance can be done. And occlusal plane analyzer can be used to decide the plane of occlusion. So there are products in this slide. The Broadtex plane analyzer have used. The upper cast is demounted and the upper cast is removed from the articulator. The Broadtex flag is attached to the upper member, upper arm of the articulator, and from the condyle and the mock-up position of the canine, arc is drawn on the Broadtex flag, and this intersecting point will give you the occlusal level. So this occlusal plane can be used as a final occlusal plane, and the mock-up can be carried out at the particular plane. So coming to the restoration of the lower posterior teeth, the posterior teeth should have an equal contact that does not interfere with either TMJ in the back or the anterior guidance in the front. So there are three determinants: the plane of occlusion, the location of the buccal crest teeth, and the contour of the fossa. So the last one is the restoration of the upper posterior teeth. Now the Mayer has given the functionally generated part technique for deciding the location of the upper posterior teeth. Now, according to this technique, we can obtain the upper teeth position, the contour, and the incline. Everything can be obtained with the help of functionally generated part technique. Now, coming to the advantage of these techniques, it is possible to diagnose and plan treatment for the entire rehabilitation before preparing the single tooth. It is well organized logical procedure that progress smoothly with less wear. There is never need of preparing or rebuilding more than 8 teeth at a time. So we can subdivide the tooth preparation time in 4 stages. It divides the rehabilitation into separate series of appointment. It is neither necessary nor desirable to do the entire case at the one time. There is no danger losing in patient's vertical dimension. The operator knows exactly where he is at all the time. The functionally generated path and the centric relation are taken on the occlusal surface of the teeth to reveal at the exact vertical dimension to which the case can be constructed. All posterior occlusal contours are programmed by and are in harmony with the both condylar bottom movement and are perfect and a perfected anterior guidance. There is no need of time consuming techniques and complicated equipment. Laboratory procedure is simple and controlled to an extremely fine degree by the dentist. So coming to the case report, now in this case report we can see the patient came to the particular clinic with decreased vertical dimension. All teeth are treated. So in this case, a verticalization splint is planned first to check whether we can increase the vertical height of the patient or not. A particular splint can be in the future can again be taken as a reference for increasing the height to check how much they have increased the vertical height. Now, this verticalization splint is delivered to the patient for 14 days of use. Once the patient is comfortable, they have checked the increase in the height of the patient, and accordingly, they have prepped the tooth. Now, once the tooth preparation is done, the splint is cut from the anterior part. The lower anterior and the upper anterior teeth are prepared and rehabilitated. Now the splint is cut in between from the medial section, and right side of the tooth is prepared, and the left side the splint is kept to check the increase in the vertical space. So this splint can be either it is an actuant in the full mouth rehabilitation cases. It can be used as an it can be used by the patient to check whether the raising the bite can be possible, and it can be used while planning the treatment. Now, the second case report is the stepwise approach to functional and aesthetic full mouth rehabilitation. So in this case, also we can see the same fully treated cases. The patient reported to the college. The lower anterior is prepared first. The lower anterior is rehabilitated. BOPA is used to check BOPA is used for the occlusal marking. So once the occlusal level is decided with the help of BOPA, the mock-up is done and the rehabilitation is carried out. So coming to the systematic review, philosophy of full mouth rehabilitation. So the aim of this systematic review is to systematically review suitable philosophy to treat the individual terminal and miscellaneous classification. So the result says that they got 26 case report, out of 15 were treated by this Pankey, Mann and Schuyler philosophy. 2 cases were treated by Hobo and 9 cases by Hobo twin stage philosophy. Now out of 21 out of 26 were introduced for the category 1 and 4 cases for category 2 and only 1 case is presented with category 3. So conclusion being, no philosophy are universally acceptable, although the most commonly used was Pankey, Mann and Schuyler philosophy. Maximum patient with burnout dentition are grouped under category 1 and the maximum cases of this category are treated with the help of Pankey, Mann and Schuyler philosophy. So coming to the conclusion, Pankey, Mann and Schuyler technique is the most practical philosophy for rehabilitation, and this simple technique provides an orderly pattern of occlusal contact and articulation that will optimize oral function, occlusal stability, and aesthetic. These are the references. Thank you.